it's my honor to introduce our moderators for the upcoming 4 sessions about pediatric neurology and neurodevelopment. We are honored to welcome Dr. Iman Al-Sayed, specialist pediatrician at Reem Hospital, who brings over 2 decades of experience in providing comprehensive pediatric care. Alongside her, we are pleased to have Dr. Bushra Hussain, consultant pediatrician at Reem Hospital with over 31 years of experience in the UAE, who will moderate these sessions with their expertise and guidance.
And welcome to our first Reem meeting and conference. We are now pleased, we'll start our next session for today for pediatric neurology and development. Our first speaker will be Dr. Dina Saleh. We thank Dr. Dina for her all effort for arranging this meeting today. We are pleased to welcome our esteemed speaker, consultant and head of the Pediatric Neurology Department at Reem Hospital, who also serves as Associate Clinical Professor at Khalifa University in Abu Dhabi, and a Professor of Pediatric Neurology at Ain Shams University, Egypt. Today, she will highlight us with a session with seizure mimickers. Please join me in welcome Dr. Dina Saleh. The stage for you.
Thank you so much, Dr. Iman, for your kind introduction, and I'm very grateful to everyone who made the effort to come and join us in our first Reem PEIDA Pearl Symposium. I hope you are enjoying our sessions and fresh back after the coffee break. So without any further delays, let's start, and I have nothing to disclose. This topic actually is very close to my heart, as I believe that pediatricians are always encountering these concerns about, I have a child, does he have a seizure, he doesn't have a seizure. So it's always a matter of confusion, and it's very crucial to make the correct diagnosis. So the objectives of my talk today is to introduce you to various paroxysmal non-epileptic disorders, how to differentiate it from epileptic seizures, identify eventual precipitating factors, and also identify the etiology and the association of these disorders to other diseases, and provide the proper approach and diagnosis and treatment. So PNAD are series of clinical events that need to be clearly differentiated from epileptic seizures, appear at any age, preferably usually in the first years of life, and they are commonly misdiagnosed as epilepsy, and also a correct diagnosis is very essential to avoid unnecessary investigations and treatment. So most of PND resolves as the child grows and the brain matures. So some authors call them as a developmental and benign movement disorders. However, they have been also described to be associated with certain genetic mutations, such as patients with tonic upward gaze and ataxia, or those with paroxysmal torticollis. They are related to CANCNA1 genes, and also alternating hemiplegia, which is associated with ATP1A3 gene mutations. Some of these also paroxysmal non-epileptic disorders are linked to some cofactors, such as breath-holding, cyanotic breath-holding events, which is linked to iron deficiency, serving as a neurotransmitter synthesis and myelin formation, affecting the neurodevelopment. This is a very old study, but it's a very nice study. Back in 2006, they did a retrospective observational study looking at all the patients that were admitted. 223 patients were admitted with a diagnosis of possible epilepsy, and actually they looked at the referrals. They found that almost 18% had doubt about the diagnosis, and 70% had referrals with no doubt of the diagnosis. Of those who were referred with a doubt with the diagnosis, 82% were not epileptic, and of those that had no doubt about the diagnosis of epilepsy, 30% had been proven to be non-epileptic. So 86% of those were on anti-seizure medications, imagine. And 40% turned to be diagnosed with paroxysmal non-epileptic events. 40% out of the patients turned to be not having epilepsy. Now this is a table back in 2009 looking at why the confusion. Some patients would present with events that can be confused with generalized seizures, such as those who have syncope or pseudo seizures. Daydreaming can be confused with absence seizures. Hypnic sleep jerks or myoclonus can be confused with myoclonic epilepsy. Now I will display with you what is the most important approach, how you could approach a child. Then you have to sit in the clinic and you have to take a very careful and detailed history. We have to look for the eyewitness, and if we don't have the eyewitness, sometimes I call the nurse, the school nurse. I call the brother or the sister who witnessed the event. I also ask for home videos if ever it's available. We need to ask about things that happened prior to the attack. What was the child doing? Was the child awake or asleep? Was the child exercising? Was he there previous postural changes? Was the child have fever, trauma? These are all important things that we needed to have it in the context of the event. And then we look at the attack. What is the onset of the attack? What is the offset of the attack? How frequent it is happening? If it's happening, does it happen in the same pattern or it keeps changing? This is also very important clue. And we look at the antecedents about family history, cardiac diseases, medical disorders, metabolic disease. And then finally, the gold standard would be, of course, a video EEG monitoring to capture the events of concern. Of course, we are not lucky enough always to have this done. Now, I will display with you some videos about the common, just to show you the common types of seizure that we encounter in the clinic. So, of course, your interaction will be greatly appreciated. So what do you think for this first child? Absence, excellent. Let's move to the next one. And this girl. This is a bit difficult. Any idea? So this is a typical of myoclonic seizures. It is the most fast type of seizures with shock-like jerks. It can be in the upper extremities, lower extremities, and can be all over. And this one? What is this? Sorry, stopped? You want me to play it again? I believe there are some delays in the video. Okay, this is focal clonic seizures. And then this is the most scary one. This is generalized tonic-clonic seizures, and you can see how fast it would be. The parents would be scared too much, and of course it's something that we wouldn't have to love to see it in our beloved ones. Okay, now we will go for challenging cases and videos. And I try to categorize these paroxysmal non-epileptic disorders as per age group. But of course, there is no, black and white. So these movements can extend beyond these age groups, but try to make it more easy for you. So if I say this is a neonate, full term, who have only hypoglycemia, and he had this kind of movements, what do you think? And he's awake, of course. What is this? Excellent. This is jitterness. Why do you think it's jitterness? So the jitterness actually is, yes. So we have, in the jitterness, we have excessive response to auditory and tactile stimulation. Usually it has a tremulous activity of back and forth oscillation of equal amplitude and frequency. And also they do have, these cases typically occur while awake, and they can cease with a passive flexion, and they are commonly encountered in patients with metabolic problems, hypocalcemia, or hypoxic ischemic encephalopathy. Okay, next. The video is a bit laggy, but the child, the neonate, is sleeping. What do you think? Again? Excellent. Benign sleep neonatal myoclonus. So, benign neonatal sleep myoclonus, it occurs in repetitive myoclonic movements, can be unilateral, bilateral, generalized, and it occurs only during sleep. So when you receive a call from an anxious mother and she sends you this video, ask her to wake the neonate. If the neonate stops doing these movements while awake, then this is benign neonatal sleep myoclonus. Generally, we don't need to do an EEG. Typically, it appears in the first weeks of life and diminish by second month, and they stop completely by 6 months. Okay, this is very interesting. Okay, so look at this, and if you have any clue, what's this? So the physician is doing nasal tapping. And you will see the newborn will doing this stiffness all over extremities. What do you think? Huh? Yes, hyper-epilepsy, Dr. Ghada, excellent. So I imagine or not, I've seen last year a 2-year-old boy who is receiving 2 anti-seizure medications, and when I was doing the knee jerk, he was, shaking all. And imagine or not, it was missed by a neurologist. So this is very important, and it's a quite rare genetic disorder with a variety of mutations, usually affecting the glycine receptor. Mostly it's an autosomal dominant. This boy has a girl who was born after him with the same disorder. Usually it's a triad of generalized stiffness of the whole body, nocturnal myoclonus, and exaggerated startle reflex. No tapping test, but please, don't do too much nasal tapping because it can induce severe apnea, bradycardia, and the child can suffer from respiratory difficulties. So we need to manually stop this. We flex the neck and the hips, and this we can abort this movement. It can extend beyond in adulthood, of course, and sometimes it responds very well to clonazepam. Okay, this is a quiz. So this is a newborn, 3 days old, having these movements. The EEG is going in the background. When further taking the history, we found that the father had the same events when he was a newborn, and it resolved on its own. So what do you think? Of course, the EEG here is an abnormal with a spike and slow wave discharges. There is focal seizures, head deviated toward the right side, I'm sorry. What do you think? What this could be? A neonate, otherwise normal, 3 days, and family history is positive. So it's called, this is the familial neonatal seizures, or familial neonatal, benign neonatal epilepsy, and it's linked to KCNQ1 and 2 gene. And usually it's self-limiting. It can occur up to 30 times per day. Now moving to the next age group, early infancy from 0 to 6 months, and this is a completely healthy baby with this movement occurring hundreds of times per day. What do you think? Any clue? Yeah, I can hear it. Okay, so this is shuddering. Okay, shuddering typically begins in infancy, clinical episodes in form of rapid shivering, usually of the shoulders, extremities, and rarely the trunk. They are usually brief and can occur up to 100 times. And of course, there is no impairment of level consciousness. EEG is normal. We don't typically need to do EEG, and also it resolves by the age of 2nd and 3rd year of life. Now this is a very challenged case. I saw it in 2010 back in Mafraq Hospital. She was 7 months old. As you can see, the child will have brief behavioral arrest, and then she will have sudden extension of the extremities. I'll just have to wait for the video. Yes. What's the first thing that pops up into your mind when you see an يلا دكتورة غادة قولي infantile spasms? Excellent. Please don't miss. This is very important. So we did EEG. It was normal. We waited 2 weeks again, and we repeated EEG. It was normal. Do we have to do this? Yes, because sometimes the EEG findings might appear later after the clinical seizure. But guess what? The EEG remained normal forever, and the child had normal development. So this is an entity called benign myoclonus of early infancy. And it's a benign and non-epileptic spasm. It's also called Fisherman syndrome. So Fisherman syndrome, onset usually typically at the age of 3 to 8 months, and it has a male predominance. Usually history is negative, no epileptic changes in the EEG, and usually it occurs while awake. On the other hand, the infantile spasms tend to occur while awake or while asleep. Now this is a typical case of infantile spasms. Okay, how I know this? I need to do EEG. And of course, I need to see that the child not doing well. He looks, sometimes the children would look uncomfortable. Their face look as if they are in pain. And this is another child. This is a beautiful girl. This had a resistant epileptic spasm. She received 3 courses of treatment. Once we stop the treatment course, she will relapse. And this is the typical EEG that we find. It's a chaotic EEG with hypsarrhythmia. However, we have many patterns of EEG described. We have hypsarrhythmia, modified hypsarrhythmia. We can have even normal EEG, but this is very, very rare. Okay, next, what is this? What is this called? Okay, so this is a hereditary quivering of the chin. And by the way, this can extend in adulthood and can be quite embarrassing. And I have a father who had this, especially in stressful situations when he gives talks and he is a lecturer in a faculty. So it's an autosomal dominant disorder, and sometimes it would respond to anti-seizure medications such as diazepams. This is also a very beautiful case. Who thinks this is a seizure? Raise your hands. Who thinks this is a seizure? No one. Excellent. Everyone is expert neurologists because we are giving the paroxysmal non-epileptic. But by the way, these two kids were diagnosed with epilepsy by an adult neurologist, with all the respect to adult neurologists, and they were receiving 2 anti-seizure medications, and the diagnosis is paroxysmal tonic upward gaze of childhood. How we know that? We know that the child in between these episodes fully conscious, fully aware. You can interrupt the episodes. It is described as a sustained upward deviation of the eyes when the child tend also to flex the neck downwards, and they can have also downbeats of saccadic movements with downward eye gaze. Of course, they might have variable degrees of ataxia. They can be typically seen in children with neurodevelopmental delays, so we have to monitor their development, and sometimes we need to do brain MRI to exclude posterior fossa lesions. Now this is another funny one. Actually, no, this is not funny. Nothing funny in neurology, right? Yeah. So this baby tends to, I'm sorry for the video, this is one of the very old educational videos. You can see the child tilting his head to one side, right? Can you appreciate this? The EEG in the background supposedly to be normal. What would you think about? Okay, so this is a case of benign paroxysmal torticollis in infancy. How we know this? It is an abnormal sustained tilting of the head and the neck. It lasts for a few hours and can last for a few days. I had a patient back 10 years, she would stay for 3 days with the head tilting, and then all of a sudden it will resolve on its own. These children might develop later on migraine, and it has been related to CACNA1A gene mutation, and they can develop migraine in the future. Okay, next. This is very common. So a baby who's brought to the clinic, she sometimes flexes, sometimes she extends her legs, and she appears flushed, sweaty. What do you think? And she doesn't like to stop these movements. I have 30 minutes, by the way. It's Self-gratification behaviors, previously called infantile masturbation. Of course, we don't use this term anymore. The patient might have grunting, irregular breathing, facial flushing, diaphoresis, and it's usually benign, subsides on its own. It's typically seen more in children with neuro disabilities, but can be seen in normal children. Now, moving to the next group of late infancy, we have this. So this is a video of a baby. You can see he has nystagmus, head nodding. What do you think? This is a case of spasmus nutans. So what is spasmus nutans? It's a triad of nystagmus, head nodding, titubation, head tilting, intact consciousness. Usually it is self-limiting and can last and resolve by the age of 5 years. Okay. This is very common. I'm sure everyone here knows this. A child who is crying, screaming, or angry, and all of a sudden he will turn blue, and then he will have this. What is this? Excellent. Cyanotic breath-holding events. What we need to do, what kind of test we need to do? Iron, excellent, because the iron is a cofactor and can improve these episodes, but he can turn to full-blown seizure, see? Do we need to lift the child? Common mistake, parents will lift the child. No, we need to keep them on supine position to make sure the blood flow back to the brain, and we need to do long strip ECG to make sure that we don't have long QT interval syndrome. Okay, next, less common palate syncope that can be induced by head trauma, pain, and it is caused due to bradycardia and asystole. They can typically be confused with seizure, and also again we need to do long strip ECG to rule out long QT interval. Next, a baby who will develop sudden loss of muscle tone when he is emotionally excited or laughing. The father is playing, I'm sorry the voice is not there, but the father is playing peekaboo, and all of a sudden the child will fall. And then again. And the EEG is normal. Any clue? These can look like head drops, actually, or drop attacks. So this is cataplexy, and we have cataplexy sometimes in neurodiversities, in cryptogenic and Niemann-Pick disorders. We can have it in symptomatic endoencephalic lesion and Prader-Willi syndrome, but we can have it also in normal children. And when we have it in normal children, we have to ask about narcolepsy. What is narcolepsy? We need to ask, does the child sleep during daytime? So all of a sudden the child is awake and all of a sudden he sleeps, because it's a common association, cataplexy with narcolepsy. Okay, this child brought to me and he was on 2 anti-seizure medications. All of a sudden, mother will have repeated events of, what do you see in the video? The child is not able to move the whole right side of the body. So this is alternating hemiplegia of childhood. And typically it's caused by ATP1A3 gene mutation, recurrent episodes of hemiplegia. It can last for minutes, for days, and usually it remits with sleep. Unlike seizures, when you have seizures, you can have seizures out of sleep or while awake, and usually it might respond to flunarizine and to topiramate. Okay, this is our biggest challenge. Now, look at this cute baby. So she was brought with this twitching movement of the eyes, and we did EEG, it was normal. We did MRI because she was young enough and we wanted to make sure that there is no underlying structural brain pathology. And we have this little smart cute boy also. All of a sudden he will have this shock-like movements, very fast. And in between he will look toward one side. So this can be seizures. Do you agree with me? Do you agree with me? Can be focal seizures or no? Yes or no? Yes. So both are cases of motor stereotypes. The boy is having something called eidetic imagery. Eidetic imagery, it's part of, it's kind of motor stereotypes. The child recalls vivid visual imaginations to keep himself happy and pleased, okay? It's at the end, it's a motor stereotype, but in neurology, we like to use fancy names. So motor stereotypes usually start before the age of 3 years. It's rhythmic, repetitive, fixed pattern. It is triggered by excitement and stress. It lasts for a few seconds or minutes. We have primary stereotypes in otherwise normal children, and we have secondary stereotypes in children with autism spectrum disorder, Rett syndrome, and intellectual disabilities. Now, the next group, which is childhood group, and this is the last group, hopefully. Okay, so we have this boy. Is the video clear? Okay, perfect. So the child all of a sudden will have sudden, yes, exactly. Dr. Ghada, you make the exact semiology. So we will do this. What we need to exclude here? What we need to exclude here? What's the most important thing? Myoclonic epilepsy needs to be excluded, so we arrange for EEG and we put EMG electrode to make sure that there is no hidden deltoid muscle contractions. And this is another miserable girl. If there is sounds, actually, the child is all of a sudden screaming, making sounds and voices, and making these movements. This girl was so desperate that she was bullied by everyone in the classroom, and when she joined the university, she decided to make a video for herself on the Facebook, and finally she got rid of all the bullying. This is tics and Tourette syndrome. Tics you tend to be repetitive, sudden, involuntary movements. There is sometimes vocalizations, and usually it occurs at a later age group, and this is how we can differentiate them from motor stereotypes. They can be motor or phonic, vocal tics such as sniffing, clearing throat sounds, saying bad words. So it can be simple or complex, and Tourette syndrome sometimes also is associated with obsessive compulsive disorder, ADHD, so we have to ask about these symptoms when we take the history. This is a very beautiful table, but I will skip it for the sake of time, differentiated between tics and stereotypes. This is another boy who looks very scared, terrified, asking his mother, "Where are you? I can't see you." And this is actually occurring repeatedly on daily basis, more than one time per day. What do we need to exclude here? and he sometimes loses balance, and he like some kind of disequilibrium. So this is benign paroxysmal vertigo, and usually it's episodes of brief disequilibrium, frightens and off balance. I remember one British girl, when she started expressing that what she feels that the buildings were falling on her. So it's very, very scary. And usually it subsides on its own. Typically they might develop migraines later on in life. These two cases are published as part of series in one about phenotype-genotype correlation. The first child was diagnosed with epilepsy and was on anti-seizure medications, not responding, having these daily events of tonic stiffness, very painful, with eyes going up, which is called oculogyric crisis. He turned to be having AADC deficiency, L-aromatic decarboxylase deficiency, and this is one of the CP mimickers. Another beautiful boy. This beautiful family, it was a very challenging case. He had 3 types of episodes. He was diagnosed with epilepsy in the first year of life, and then he developed these kind of movements on daily basis. And also annually he had events of ataxia. And he was again diagnosed with epilepsy, but he turned to have infantile convulsions with kinesogenic choreoathetotic dyskinesia due to PRRT2 gene mutation. I'm sorry for that, but last, sleep disorders, sleep-related disorders. Do you see this in your clinics? So a baby coming on daily basis almost, she will wake up in the first part of night, crying and screaming, looking confused, sometimes lasting for 30 minutes or 1 hour. What do you think? Night terrors, excellent. So night terrors, we need to know exactly, take a detailed history of night terrors, because our biggest differential diagnosis is frontal lobe epilepsy. Okay, so mostly it occurs at the age of 3 to 8 years, usually occurring during the non-REM sleep in the first third of the night, and usually there's autonomic features, tachycardia, flushing, the child looks terrified, very difficult to, inconsolable, and lasts for 5 or 15 minutes, and usually it's a single event. Now when we look at this child, he looks frightened, he's doing this is called fencing, okay? And when we take the history, we'll find that it lasts for seconds, less than 2 minutes. It tends to occur in clusters. Usually there is a prominent motor activity, tonic posturing, hyperkinetic movements. It can occur many times at the same night, and maybe they can go outside the room, and this is frontal lobe epilepsy. And also for the sake of the time, there is a very beautiful table to differentiate between these two disorders based on age of onset, stage of sleep, timing, repetition, duration, and so on. Okay, this is another case. This is child awake, complaining of tingling sensation, followed by jerking hand movements or arms. What do you think? Is it epilepsy, not epilepsy? Epilepsy? Raise hands. It's epilepsy, okay? But the child actually, and he was given anti-seizure medication, very well controlled. Then later mom comes to tell you, no doctor, he's not controlled. He's still having these movements during sleep. What do you think? Okay, this is hypnic sleep jerks. All of us have hypnic sleep jerks. So again, videos are very important. We can have a child with epilepsy with other paroxysmal non-epileptic disorders. Okay. GIT, Dr. Ahmed, of course, GIT disorders have been related to many paroxysmal non-epileptic disorders. One of the most common is Sandifer syndrome, which is related to gastroesophageal reflux. The child will tend to...
Dr. Dina, 2 minutes more.
Yes, 2 minutes, I'm finishing. So this is easy for all the pediatricians. Also, there is a paper that have described 4 cases with real seizures with the stool withholding, severe constipation. They tend to flex their legs, push forward. They appear vacant with deviation of the head and the eyes toward one side. However, development was normal, EEG is normal, everything was normal. Now, this is a quiz for the audience. I need interaction. This is seizures or not seizures? A 5 years, I think it was 4 or 5 years old girl, so she's having these kind of events. Who says this is seizures? By the way, she's screaming in between, looking terrified. Seizures, who would say this is seizures? No one? Dr. Amira? Dr. Amira, you are right. This is seizures, okay? This is seizures, and this is called circular seizures. And this is very common in frontal lobe, not very common, sorry. This is seen in temporal lobe or frontal lobe epilepsy. Okay. The other boy, this is seizures? Huh? Not seizures, sure. If you hear the voice, you really feel so sad about the parents. The parents were so scared. They were saying, La ilaha illallah, la ilaha illallah. The child was faking this. You know, the child wanted an iPhone and the parents refused to bring him the iPhone. So he just saw a YouTube video and he's starting spitting and, you know, doing thrusting movements. So this is definitely not seizures, okay? See how teenagers can be challenging. Sorry? I can. No. But he was spitting. Dr. Ghada is asking a very question. Did he lose continence? No. Which is against, of course, there is a list that how can we differentiate pseudo seizure. So my take-home message today: numerous paroxysmal spells in children may be non-epileptic. We need to include PNED in differential diagnosis, especially in new onset epilepsy, when everything is fine except seizure. When the seizures are not responding to medications. So expert neurologists have to step back and revise their diagnosis. It's not something مش حرام يعني كلنا بنغلط. We can step back and revise our diagnosis, and always we need to suspect when we have always normal EEG. Misinterpreting EEG can be very costly. Most important tools: careful clinical history. Home videos is important. The gold standard would be video EEG monitoring. And here these photos to convince the audience. Neurology is not as bad as you think. We do have stressful situation, hard times, but we also share enjoyment with our patients who consider you your role model. They want to be doctors who share with you their enjoyments, celebrations. And this is a child with extreme thyroid neuronal lipofuscinosis who made this Lego in 6 months. And those who already left the country or joined the university. And of course, this would not have been achieved without an excellent team supporting us. Thank you so much.